To start with, defining what we mean by progressive MS, that trying to understand some of the mechanisms that underpin progression, which we've been discussing today but are still far from clear, and then based on that understanding, identifying treatment targets, which we don't have at the moment. So, we have lots of treatments for relapsing remitting MS, nothing at all for progression. And going from there, once we've identified targets, perhaps thinking about the trial design and the outcomes that we might need to demonstrate benefit. So there are problems, or issues, or challenges all along the way, from the very basic neuroscience through to a clinical treatment. Well, I think if you look at the recent phenotype paper, what you need to be clear about is that there's a gradual increase in disability over time. So it's a clinical definition, which in itself has limitations. And that increase in disability is independent of relapse activity. And of course, as you know, we've got these two forms of progressive MS, primary progressive and secondary progressive. And the consensus of opinion, and I agree with it, is that these are not absolute differences, these are relative differences between the two. And underpinning both is this neurodegenerative process, which is linked in some way, as yet undefined, with the inflammatory process, which we know that occurs in MS. Well, I have a slide which describes, how different people define it, whether they're patients, doctors, and even among doctors, whether they're radiologists or pathologists, clinicians. I think it has different implications for each group, but I think the fundamental process is the same. And I suppose if you were to say, what it means for all of us is that it's the most challenging group. It's the area that we still haven't really conquered, and it is the big challenge going forward for the next decade. Of course, that transition from relapsing remitting MS into secondary progressive is something which you almost define in retrospect. So, people don't have the sense that I'm moving into the progressive phase. The physician rarely identifies it. So you're looking back, but when you say to somebody, look, I think you now have progressive MS, it has a huge impact on them, because they now see this rather, not relentless, but ongoing deterioration over time. I think if we had very clear markers of that, so we could identify when people were approaching that phase, that transitional period, and could get in there with something that prevented it, that would be a fantastic achievement. Absolutely, that's too long. I think, it is, when I started, we had no treatment, so it was all about management, and even then it was quite nihilistic. We now have 10, 11, 12, 13 treatments. But we also have indications that we are addressing the issue. So when progressive MS, you're looking at repair, and you're looking at protection, so it's a different process. But we have some indications that we're getting a handle on that, not from the agents that suppress inflammation, but for things like the statin study, for example, in secondary progressive MS. That showed a clear effect on disability on imaging. We have a few interesting studies around neuroprotective agents like phenytoin, Raj Kapoor's study at American Academy, perhaps this biotin, this other new agent. So I think that there are things already starting. So I would like to think, we may be looking at combination therapy. That's the other issue. So it may be too simplistic to think of a single agent that could actually do this. But I think we're over the next 5 years, I would really like to see some big change. And that, of course, is the other thing I'll be talking about tomorrow, is the Progressive MS Alliance. This coming together of all the major MS societies to try and focus on progression. And that's their goal, our goal in the next 5 years, that we will actually have moved forward into early and perhaps phase 2 trials in progressive MS.